Hello, my name is Vanessa Baratta. We would like to thank SAGES for the opportunity to present our work, titled The Role of Laparoscopy in the Surgical Management of Ileal Pouch Anal Anastomosis Complicated by Pouch Prolapse and Pouch Volvulus. Dr. Silla serves as a consultant for the following. The remaining authors have no disclosures. Total proctocolectomy with ileal pouch anal anastomosis is the preferred surgical therapy for ulcerative colitis that is unresponsive to medical therapy or associated with dysplasia. Many studies have shown that patients benefit from a minimally invasive TPC with IPAA. However, 30 to 60% of pouches can develop both short or long-term complications, including inflammatory, functional, and mechanical issues. Pouch prolapse is an uncommon complication of ileopouch anal anastomosis with a reported incidence of 0.3 to 0.4%. It is defined as excessive protrusion of the pouch wall into the lumen. Pouch prolapse ranges in severity from partial mucosal redundancy to full-thickness prolapse. Partial pouch prolapse is often managed non-operatively, whereas full-thickness prolapse requires surgical intervention. If there is full-thickness prolapse alone, pexy is appropriate. If there is volvulus or torsion of the pouch, then detorsion and pexy is appropriate. When the pouch is ischemic or necrotic, pouch resection may be necessary. There is limited information regarding the role of laparoscopy in the management of pouch complications. Our aim was to evaluate the incidence and outcomes of pouch prolapse and pouch volvulus and the role of laparoscopy at high-volume tertiary referral centers for IBD. Using a prospectively maintained IRB-approved IBD database, all patients who underwent IPAA for inflammatory bowel disease from 2008 to 2018 at Mount Sinai Hospital were evaluated for diagnoses of pouch prolapse or pouch volvulus. Diagnosis was based on inpatient and clinic notes from colorectal surgeons and gastroenterologists. Data on patient demographics, symptomatology, treatment, and outcomes were extracted for analysis. Of the 665 patients who underwent 2 or 3-stage restorative proctocolectomy with IPAA, 11 patients, or 1.65%, developed pouch prolapse, and 2 patients, or 0.3%, developed pouch volvulus at 31.4 and 15 months from IPAA creation, respectively. In this group overall, 61.5% were women with a mean age of 28.5 years and BMI of 23.6 kilograms per meter squared. Indication for surgery was medically refractory ulcerative colitis with laparoscopic 3-stage RPC performed in 12 patients and 2-stage in 1 patient. All pouches were stapled J pouches except for one hand-sewn anastomosis and a pediatric patient. The mean time between diagnosis and J pouch construction was 31.4 and 15 months for pouch prolapse and pouch volvulus, respectively. In the pouch prolapse group, 5 out of 11 patients had partial pouch prolapse and presented to the IBD clinic with straining, anal pain, or endoscopic findings of mucosal prolapse. All patients were managed with fiber supplementation and 2 were referred for biofeedback therapy. On follow-up, from 24 to 60 months, 45 patients had symptom resolution except for 1 female with pelvic organ prolapse. 6 patients had full-thickness pouch prolapse, of which 4, or 66.7%, underwent laparoscopic repair. The remaining patients were managed with open pouch pexy or laparoscopic converted to open pexy. All elective cases were successfully managed laparoscopically, 3 out of 3, compared to 33%, or 1 out of 3, of those with urgent indications, which included ischemic pouch in 2 and bleeding from a rectal ulcer in 1. 2 patients managed with laparoscopic pouch pexy developed recurrent prolapse and underwent redo laparoscopic pouch pexies without recurrence at 36 and 42 months. The 2 patients managed with open procedures had complications preceding the diagnosis of pouch prolapse, including a closed-loop bowel obstruction and an intra-abdominal abscess. Of the 2 patients with pouch volvulus, one was managed with an open detorsion and diverting loop ileostomy with reversal, and the other was managed with rigid sigmoidoscopy followed by laparoscopic detorsion and pexy. In both cases, the pouch was salvaged and there was no recurrence to date. In conclusion, laparoscopic approach was feasible in the majority of cases. Pouch salvage was achieved in 100% of cases, and partial mucosal pouch prolapse can be managed conservatively. We propose that laparoscopy is a safe and effective method to repair IPAA-related pouch complications in centers with experience in the surgical management of IBD. Thank you.